typical drugs we use to control or influence blood pressure and cardiac output. And you see me run around, and I'm always frustrated because we're all focused on the blood pressure, but because that's the big red number that everybody looks at. But in the corner is a box that has a cardiac output, and we're going to just break these few medications down, because there aren't that many that we use post-operatively to increase cardiac output and increase blood pressure. They fall into very simple categories, and it's always back to basics. It's always back to the Starling curve. Pulmonary capillary wedge pressure goes up, muscle stretches, contractility increases, and cardiac output is related to filling pressure. All the medications that increase cardiac output do is take the Starling curve and move it up so the heart contracts more efficiently. That's all they do. They go about it in a different way, and they have other side effects, but the medications that increase cardiac output just change that individual's Starling curve by increasing myocardial contractility. The medications typically are catecholamines, with one exception that we'll go over. And catecholamines are secreted by your body, so they're natural occurring chemicals. The catecholamines have two effects. There's an alpha effect and a beta effect. Beta is broken down into subcategories, but for what we're talking about, it really doesn't matter. Alpha simply increases blood pressure, and it does so by increasing peripheral vascular resistance. You can think of it as it grabs all the smooth muscle that's in your body and squeezes it. It decreases blood flow to certain areas. That's how it works. The alpha constrictors and the ones that are alpha, the purest alpha is basically vasopressin and then levophed. Where is it? Norepinephrine. Norepinephrine, levophed, and vasopressin are strong alpha. Levophed, norepi, also has some beta agonist, and what pure beta would do would be increase contractility and heart rate. So the beta agonists, heart rate, contractility. And all we're doing post-operatively is balancing one against the other. And if you look at someone who you want to increase their blood pressure, and their blood pressure alone, you'd use vasopressin. It will decrease blood flow to certain organ systems. So pure alpha agents can be quite dangerous to use, particularly in old people. Because if someone has coronary artery disease, almost by definition they have atherosclerotic occlusive disease in other organs. What are the organs we're worried about? In old folks, their GI tract, their kidneys. So if you put someone on alpha constrictor, basically takes the blood out of the periphery and centralizes it and protects the brain. It also decreases blood flow to the bowel, the splanchnic arteries squeeze down, decrease blood flow to the bowel. Someone already has some fixed stenoses there, those folks are going to end up with ischemia to the GI tract. And it's not going to show up right away. You're not going to see it right then and there. You get the patient through the crisis, they come off alpha constrictors, you're happy about it. You go home 3 days later, they got an extended abdomen and they're acidotic. It's a result of these things being used as pure blood pressure raising agents without trying to monitor what their cardiac output is. So if we're going to put people on alpha constrictors, it's a temporary thing to try to get them through a crisis. We'd like to use concomitant beta agonists, which will increase myocardial contractility and cardiac output. So they balance each other. And the way the medicines interact is kind of the art of medicine as to how to get it to work. All catecholamines also increase myocardial oxygen consumption. So it goes back to this curve. If something's squeezing harder, it's going to use more fuel. It's just like a car. You know, if you hit the gas and you're going faster, you're going to use more fuel for the same distance you go. So you keep that in mind as we try to manipulate these drugs. We're relying on the engine to do the work, and the engine's paying the price. So you crank somebody up on epinephrine unnecessarily, you're paying a price from a physiologic standpoint of increasing myocardial oxygen consumption, myocardial workload, which potentially could cause problems down the line. So the only drug that's the real exception to that is milrinone. Milrinone is not a catecholamine. Milrinone is a phosphodiesterase inhibitor, and it increases myocardial contractility using a different pathway. And textbooks will tell you that it doesn't do so at the cost of energy being burned, but in actual fact it does. It also is a peripheral vasodilator. So if you put someone on milrinone, I'm sure you've seen this. Milrinone we don't use routinely, but if you have someone that you just put on milrinone purely, number one, it'll take a while for it to work. When it does, their blood pressure is going to go down. You see these folks who come out with cardiac outputs, cardiac index of 4, and their blood pressure, mean blood pressure is 40. That's milrinone, and the heart was going like this, and that's where vasopressin and levophed come in, because almost everybody who ends up on milrinone for myocardial contractility is going to end up on an alpha constrictor until we start weaning it down. Okay, so that's the basics. And if you look at the drugs that we use, norepinephrine, if you kind of want to figure it out, is a big alpha and a little beta. Epinephrine is basically alpha and beta, and as you go up into higher doses, alpha becomes more prominent. So if you start going above about 0.1 microkilo per minute, what you start seeing for epinephrine is for the increase in myocardial contractility, you're getting a lot more alpha constriction. And the thing about alpha constrictors is you'll also notice that PA pressure goes up as well, because all it does is it clamps smooth muscle. And smooth muscle in your pulmonary vasculature is going to get clamped down, and smooth muscle in your peripheral vasculature is going to get clamped down. So if you watch closely, if you put someone on alpha agent, you're going to see the PA go up. It's not because they suddenly got more fluid, which is all what we think about. It's because the pulmonary vascular resistance is going up. Dopamine is basically, at low doses, is a beta, and as you get to higher doses, alpha takes over. It's very similar to epinephrine, but not quite as powerful. Dobutamine is a lot of beta agonistic and very little alpha. Levophed, which is the same as norepinephrine, talk about alpha. Vasopressin